Welcome, and thank you for joining us today for Clearing the Air about lung cancer in women, part of our Value of Diagnostics within Women's Health series. I am Irene Ninge, Chief Science Officer for the Society for Women's Health Research. SWHR is a national thought leader in promoting research on biological sex differences in disease and improving women's health through science, policy, and education. Spanning from simple blood tests to x-rays to invasive procedures, modern diagnostic tests and procedures are an essential part of clinical care, aiding in the detection and monitoring of diseases and informing treatment decisions. Innovations in diagnostics can provide access to valuable information to help women make informed decisions about their health care across every stage of their lives. As such, SWHR's Value of Diagnostics within Women's Health series highlights the importance of advances in screening and diagnostic technologies and approaches throughout the lifespan, with a focus on how we can improve health outcomes for women, particularly relating to reproductive health, healthy aging, and cancer. We are pleased to have two distinguished panelists joining us for today's public forum in recognition of November being National Lung Cancer Awareness Month. Dr. Rafael Bueno, Chief of Thoracic Surgery at Brigham and Women's Hospital and Professor of Surgery at Harvard Medical School, and Erica Sword, National Assistant Vice President of Advocacy at the American Lung Association. I would like to thank the sponsor of today's event, Roche, and SWHR maintains independence and editorial control over our program development, content, and work products. We will be live tweeting during this event and invite you to use the hashtags SWHR Talks Diagnostics and SWHR Talks Cancer on social media. Lung cancer is the third most common cancer and the leading cause of cancer deaths in the United States. Often diagnosed after the cancer has spread, early detection is a critical public health need to improve survival rates. For decades, lung cancer was characterized predominantly as a disease in men who smoke, resulting in guidelines for screening, molecular testing, and treatment largely based on this historical pattern. However, 1 in 17 women are at risk for developing lung cancer, and adenocarcinoma is more common in women than men and is the most common type of lung cancer to occur in individuals who do not smoke. Today's public forum will highlight sex differences in lung cancer that can guide us towards better prevention, diagnosis, and treatment for women, as well as emphasize ways to empower women to adopt healthy habits that may improve lung health throughout the lifespan. I'll now introduce Dr. Rafael Bueno to talk about sex differences in lung cancer pathology and outcomes, and the value of diagnostics to support prevention and early interventions for healthy aging in women. Thanks for joining us, Dr. Bueno.
Thank you for inviting me to participate today. I'm going to give an overview of the sex differences and disparities, differences in lung cancer. I'll talk a little bit about diagnostic processes and screening and lifestyle interventions for wellness and preventative care. So some recent and older studies about the incidence and how lung cancer occurs in women are going to be the first topic. And starting in the 90s, people looked at the differences. This is an example of a paper looking at the United States database from many states, and they identified and went through the large number of patients to get specific data showing that that there are differences between premenopausal and postmenopausal lung cancer in women. And when we really boiled everything together, we found that while adjusting for the various stage histology and other parameters, postmenopausal women had a higher death from the lung cancer. And that was different from men. Now, in another study, we examined women by race into the three categories pointed out here, 18 to 44, 45 to 49, and 50 to 90. And we analyzed the demographic, the socioeconomic factors, et cetera, in a large number of women from a different national database encompassing 20 years of lung cancer. And we found that compared to their white counterpart, young Black patients presented more commonly with advanced disease, have a higher early mortality, even though they live closer to the hospital. But they were from probably inner city in terms of disadvantaged setting. So we can already see that women in general have variations in lung cancer based on age, pre-postmenopausal status, which is correlated, as well as race. And another look was looking at younger women with lung cancer. And they are more likely to be non-white and more likely to be never smokers. Again, 20% of women who get lung cancer are never smokers. They did well because they're younger and had the typical symptoms, but they are more likely to have more advanced disease, which means they at a higher stage required neoadjuvant therapies. So in addition to age and race, we can identify the parameters in the smokings. And how do we manage lung cancer? Well, we can very easily treat early lung cancer, and the key is to discover it early. So there was a pivotal test 12 years ago published in New England Journal of Medicine that demonstrated that in patients at risk, CAT scans that is inexpensive and covered by insurance has a significant benefit in terms of survival. Not only do those scans identifying lung cancer earlier, they also potentially identify other cancers. And the impact on survival are higher for women than men. There were additional studies to confirm the findings. There's a study from Holland and Denmark that shows that if you screen women with lung cancer, the mortality reduction is 60%. And why is that? Because you get the cancer early and you can treat it and you can cure the patients. Now, the criteria for who's eligible for basically free staging is men and women aged 50 to 80 years who are in reasonably good health, are former smokers or current smokers with or having quit in the past 15 years with 30 or more pack years of smoking. While this has showed great promise, it does not necessarily address younger women and women who did not have primary smoking, but you got secondhand exposure from the workplace or the home. Now, this is just a current snapshot from our division. We have a very large division of thoracic surgery. And when we looked in the last 7 years, we found among 3,500 patients or so that the majority of the patients that present to us were women. And 22% were never smokers, as opposed to 15% in the men. But everybody else was either a past smoker or a current smoker. So even if you, at least my message is, if you're a young woman and you never smoked, but you lived in a place where other people smoked, or someone in your family had lung cancer, I urge you to get screened. And in addition, I would point out that only 6 to 10% of people who are eligible for screening with CT do so. If we just triple it or quadruple it, we'll save so many more lives that we can. Now, how do we address screening? Screening basically, if you fit the criteria, you get a low-dose CAT scan, which has very, very few risks from radiations. And then the radiologist will read it, find out if you have a nodule, and based on the size and shape, they'll either say you're fine, come back in the next time, or there is a problem. We can either follow it, or if it's significant enough, we can use various strategies to make a diagnosis. And I'm showing you here navigation bronchoscopy, which is an outpatient method of taking a bronchoscope, which is a tube that can go down the throat while you're asleep, and guide a needle robotically straight into the nodule that we see on a CAT scan, and for diagnosis. The diagnosis is 80% sensitive, which means 80% of the time, if it's cancer, you'll find it. And then we can use very safe, minimally invasive surgery to get the cancer out, and that's all you need for a cure. Now, I alluded to smoking. The best thing you can do is to stop smoking. The second best thing you can do is to get screened. Best both. Smoking kills more than 200,000 women a year, making it the largest preventable cause of death. And smokers have a way higher risk for multiple causes of death. And, 26 times the risk of lung cancer, which really is more, the death from lung cancer in women is more than ovarian cancer, breast cancer, uterine cancer, etc. combined. So that's really the highest risk for women. And you can see the risks of other diseases. Smoking is bad. When you quit smoking, you get slowly better, and then your risk for lung cancer drops after 10 or 15 years. Not to normal, but much, much better. So there are lots of benefits of quitting smoking in terms of fertility, pregnancy, lung functions, calcium and fractures, and improved response to any treatment for anything, and better survival. So really, if I can pass 2 messages to you, is get screened if you're a smoker or former smoker or have family history of lung cancer. Message number 1. Message number 2, quit smoking. It's good to you in so many ways. And I hope I address this. Now, Mary Cooley, Scott Swanson, and Fatima Wilder are colleagues and members of my faculty who produced some of the work that I shared with you. Thank you.
Thank you, Dr. Bueno, for that introduction. And I'd like to note for those that are tuned in live that you can submit questions at any time using the Q&A function in the Zoom feature. And we will try to address as many as we can during the panel discussion portion of this event. Next, we will have Erica Sword, who will discuss gaps to address lung cancer research and care for women. Thank you, Erica. Welcome.
Thank you. Really glad to be here today. So I want to lean in a little bit on some of the things that make lung cancer and being diagnosed for lung cancer such a challenge, especially for women, but also for people of color, and just more broadly, some of the issues that are associated with this. And the Lung Association has a number of different patient advisory groups and caregiver groups and other groups with whom we regularly discuss issues and seek information from and provide support to and hear from. And I'm going to draw for my initial section of my comments, really focus in on one of our women-only patient advisory groups in the lung cancer space, and share a little bit about some of the survey data that we have collected from them over time. And so I've summarized, I'm going to go into detail about all 5 of these different issues, but really I've summarized the main areas around which we hear the greatest need for people, for women who are battling lung cancer. And I think the first thing is a lack of support. Oftentimes, there is a lot of need for people who are battling cancer, and that's especially true for women. We tend to have a harder time asking for assistance and do a lot of the day-to-day COO work of the household. So talk a little bit about that. Concerns about the medical system, lack of knowledge sometimes about lung cancer, fear. Lung cancer is an extraordinarily serious disease. And has been the leading cause of cancer death in the United States for many years. However, certainly, as Dr. Bueno made clear, earlier diagnosis greatly increases 5-year survival, but we also have a whole host of new treatments and other ways that people are living longer and longer with this, and then finally stigma. So let's talk a little bit about the barriers and unmet needs, challenges for getting away from work or family responsibilities, and really the inability to add one more thing, which is really a challenge. Certainly, ongoing access to care, and the huge disparities that are caused by that, particularly in states that continue to not pass Medicaid expansion. The 12 states that were doing that. We just talked to a patient in Tennessee who during the pandemic was able to have coverage through Medicaid, and now she's in a situation where she's back in the coverage gap, and she is really unable to have healthcare even as a lung cancer patient. So we also know that there's a lack of knowledge among people about lung cancer. The risks, certainly, that Dr. Bueno talked about, the 20 pack year history. So a pack year is like a pack a day. If you smoked a pack a day for 20 years, you have 20 pack years. If you smoke 2 packs a day for 10 years, you still have 20 pack years. So a little bit of math there. Also an understanding of kind of some of the symptoms and whether or not they apply to other things there too. We know that there's a lot of distrust and still suspicion of health information. And one of the reasons that I'm so thankful that the society is doing this webinar today is the need for trusted voices and trusted sources to be able to provide information, and making sure that patients are able to find both a trusted provider, but also a culturally appropriate provider who understands a little bit more about that. Certainly the fear of living with lung cancer, and then finally the stigma. This is unfortunately a question that our patients tell us they hear way too much. So did you smoke? That might be the best or the worst thing to ever ask someone when they're diagnosed with lung cancer. No one deserves lung cancer. Even if you were a 2-pack a day smoker for 50 years, you don't deserve lung cancer. Really recognizing the predatory tactics of the tobacco companies, and them preying and addicting our nation's youth and young adults for so long. And really encourage people to look at our website on this information, lung.org/stigma. It has a whole host of different materials, and particularly relevant for people in the medical system to understand how they can better talk to their patients about their risks of lung cancer, but then ultimately at the end of the day recognize that it doesn't matter. That's where they're here. We need to make sure they get help quitting if they still smoke, but after that, let's focus on the lung cancer. Really recognizing that not enough people are being screened who are at high risk. We estimate only 6% of individuals who are eligible for screening in the US have gotten screened. That's 14.2 million people in general, but it's 6.3 million women are currently eligible for screening. and they have not gotten screened. So the Lung Association sponsors this campaign with the Ad Council to really talk about Save by the Scan, which is on our website, savebythescan.org, and continuing to follow up on the import. We have a little quiz that people can take to really raise the benefits. And so far, we've had over 1 million people take the quiz and then follow up with their provider if they meet the eligible criteria and qualify about getting scanned. Talk a little bit about some legislative opportunities right now and really what, from an advocacy perspective, which is what I do, we are looking to do. And so this last Tuesday, the Lung Association released our State of Lung Cancer report that compares states for these 6 categories, really looking to see kind of which state is doing the best on different areas. We really dive deeply into racial and ethnic disparities, less so gender disparities in this report. But it really does provide a roadmap for what both states and the federal government need to do to improve the terrible toll that lung cancer takes in the United States. And our call to action this year for that report was supporting and urging people to talk to their members of Congress about the Increasing Access to Lung Cancer Screening Act, which is led in the House by Congressman Higgins, Castor, and Fitzpatrick from Pennsylvania, bipartisan legislation, really aimed at increasing access to lung cancer screening and quit smoking treatments, especially among the Medicaid population, as well as increasing awareness. So encourage you to check out this. And if your organization hasn't endorsed it, that you should. We also have focused in on this particular legislation, women in lung cancer legislation that the late Senator Dianne Feinstein has introduced with Senator Rubio for the last number of years, really trying to bring greater awareness around lung cancer and highlighting additional need for evidence-based early detection tools. We have a major threat to lung cancer and other preventive services, and the access to cost sharing, to access to these preventive measures without cost sharing. It is the Braidwood lawsuit, Braidwood v. Becerra. This is currently in the Fifth Circuit and is a major threat to people having access to lung cancer screening and other tobacco cessation and other preventive services without cost sharing. I'd be happy to go into more detail in the Q&A on that. And I also just want to share another threat, which is that while the amount of funding for NIH has steadily increased and the amount of money that has been allocated to lung cancer research specifically has dramatically increased since fiscal year 13. You can see 130% increase. The current efforts in the House especially would have a devastating impact on biomedical research, including lung cancer research, as well as funding for CDC and both the Office on Smoking and Health and the Division of Cancer Control. And it's very important that as people who care and women who care about lung cancer, that this be a priority for us. So finally, I'm just going to speak briefly to the importance of women and populations and people of color to participate in clinical trials. And we've heard that the brand new NCI director who was just appointed is going to make this one of her priorities too, which I'm very thankful for. Ultimately, women and people of color are very underrepresented in clinical trials. We did some additional survey work in this space, and one of the key findings, in addition to that some of the importance of community organizations and doctors in all of this, is encouraging women to participate in lung cancer trials should take less work than men. Especially when you explain the background, and that really overcoming this guinea pig status and helping people understand that it's cutting edge treatment as opposed to the current course of treatment is a really important action, and that it's not a placebo, but it is really breaking new ground in clinical trials. We just in general know that the awareness measures and the reasons for participating in clinical trials are on this screen. And a lot of it is really the lack of relationships that people may have, and that's particularly important for women, whether it's fear of the unknown, fear of mistreatment, and that bad relationship with doctors, how important all of this is for improvements, especially for women. And so I don't think I have time right now to share a video, but I do encourage you all to come to the Lung Association's website to see some of the work that we're doing here in this space, as well as see some of the videos that we have both from Bishop Goldsmith from Oklahoma and one of his parishioners, an incredible patient advocate that has worked with us for a number of years and has been in 2 clinical trials, Edward, to understand a little bit more about how important it is to meet women where they are at, using other women as ambassadors, but also the same happens for other community outreach and targeting. So with that, I will stop and look forward to the rest of our discussion. Thank you.
Thank you very much. And I invite the panel to turn their videos back on so that we can engage in this conversation. Again, thank you, Erica. And we invite attendees to submit questions. We have a couple that have come in using the Q&A function at the bottom of your screen, and we will try to address as many as we can and focusing on overarching ones as well. Please note that our conversation today is intended for educational purposes and is not intended or implied to serve as a substitute for personal, medical, or professional advice. We encourage all patients and consumers to confirm information and consult with your healthcare provider to determine your individual needs. And so to open this conversation, I'd like to start with circling back a bit to this long-held thought that lung cancer is a concern limited to smokers. And so, Dr. Bueno, you mentioned it, and also Erica, you also touched on this. You know, what does the research say? Why are women so vulnerable to certain types of non-small cell lung cancers, even if they haven't smoked?
So the way to think about it, if I may, is that it's about 2 things. The way we think about it academically in research is that there is a risk that you have in your makeup, in your genes, that can cause cancer if a certain foreign substance turns it on. So think of it as for a light switch. It's a very simple explanation, but it's way more complicated. But so just because you don't smoke doesn't mean you're not exposed to smoke. You know, there's a great example of a case of stewardess in airplanes in the 60s and 70s who didn't smoke but got lung cancer because they're in smoke-filled cabins. So just not smoking, but being in an environment that other people smoke predisposes you, so that you get a dose of smoking. And if you have some genetic predisposition to develop lung cancer, and it's not an easily testable predisposition, it's complex, then you're more likely to get lung cancer than someone who, let's say, was raised in a place where there is no exposure to smoking. And you know, there are probably other elements that can predispose to cancer, other substances, but they're less common. Since smoking is so common, these end up being less common. So radon, living in a place where you have radon exposure, if you happen to be a plutonium miner or a nickel miner, you can get it. But those are small numbers because not a lot of people are plutonium or nickel miners or have radon. A lot of people live in a place or work in a place where there's a lot of smoking around. I hope that answers your question. Women do not get more lung cancer than men. but women are more likely to be non-smokers and get lung cancer.
I think there's a whole, I really wanted to lean in on Dr. Bueno's comment about radon. January is a month that we typically talk about radon. So radon is an odorless gas that can appear that appears naturally and that can be present in homes, offices and other schools and other locations. And the only way to know if you are exposed to radon is through testing. We often say that January is a very good month to do a radon test in your home, and we certainly have more information on the Lung Association's website. But it's important that everybody do a test for radon in their homes, and then and if need be, to mitigate and to find a licensed provider who can safely mitigate your home. And it's not too complicated, but it is certainly very life-saving. We also know that the more kind of risk factors you put on top of each other, the more likely you are to build up to a lung cancer case. So maybe you were exposed to secondhand smoke. Maybe you live in a home that has higher than safe radon levels. At some point, you're going to reach a tipping point if your genes are so predisposed, and that's certainly something that can go. But I think in general, with the younger women developing lung cancer, we still have a lot more to learn. But we ultimately know at the bottom line is that no one deserves lung cancer. And the more we can do as a society to acknowledge that and to recognize that, the better off all of us will be.
But and if I might add, you need to advocate for yourself. And so if you're a non-smoking woman who, or frankly, a non-smoking man, I have a whole lot of patients like that who have grown in a home where one of your parents or both of your parents smoked heavily. You've been exposed in the most vulnerable time. So, or if you live with someone who smokes, go to your primary care doctor and tell them, I want screening CT, and they usually will yield.
I think I do want to just follow up on that it's very important to know that right now, unless you meet those high risk criteria, you will not be eligible for a TC scan without cost sharing. And so I think, and that's important. We've had the American Cancer Society has come out with updated cancer guidelines, but there are limitations right now with only the criteria being talked about by the U.S. Preventive Services Task Force, the being between 50 and 80, having 20-pack years, and having quit within the last 15 or still smoking. That is your only way that you're going to get lung cancer screening in most insurance plans without cost sharing. Otherwise, it is not something that is available without cost sharing, and people just need to realize that going into it.
I was actually about to ask about the what those factors are, because we've had a couple questions that came in regarding that. And so while you can, as Dr. Bueno mentioned, you can make that request and you can do it. It's the costs of it that you're saying, Erica, would make the difference.
Yes.
And if I might add, because this is a perfect time for that, it's roughly $200 or something like that. It's a Christmas present that can save your life.
And so I guess to that tone, access to advances in screening tools or innovative tech diagnostics can be a significant barrier, right? And so how can we better support access and coverage to preventive screening or to various interventions?
The very top thing that we can do is for the remaining states to expand Medicaid. That is the biggest way, and the way that if the remaining states would expand, that we can make the biggest difference in making sure that people have access to quality and affordable health care. We are right now in the middle of open enrollment for healthcare.gov. And there are so many different subsidies and other ways to really have lower premiums available, that if you are currently without cancer, or I'm sorry, without healthcare, it is worth going to lung.org/open enrollment to learn more about all of this, or to go to healthcare.gov to put in information, and also potentially see about a navigator. Once you have quality and affordable healthcare, and watch out for junk plans. You do not want to go off and find a broker and end up with a junk plan. But if you can go to healthcare.gov and find a quality and affordable health plan, then that opens your opportunity to those preventive services without cost sharing.
The second thing you can do is get screened if you fit criteria, because unfortunately, only 6 to 10% of patients or people eligible to being screened are using that opportunity to screen themselves. So that's free.
Yeah. And this kind of slides into another question that has popped up about COVID-19, the pandemic, and lung cancer survival rates, and if there's any relationship. And we do know that across the board, a lot of preventive screening was on hold to reduce during the earlier portion of the pandemic, and a lot of individuals are catching up. A lot of healthcare practices are also trying to catch up with missed preventive care and screening and diagnostics. And so is there anything in particular that folks should be, because knowing the respiratory impacts of COVID-19 and in long COVID, is there something that you like to kind of mention would be important to note?
I would say that there is no causal link yet between COVID and lung cancer. I don't think there is. I can't predict the future. But that should only hasten you to get screened. Because there's some programs that stopped screening for a while, some that continued. Even if we catch people in a more advanced cancer, that can get treated. I mean, it's the sad part is to identify, and unfortunately, I identified people who were eligible for the program go to the hospital with advanced cancer that could have been easily caught early and their life be saved.
I did want to capture just a bit of note for some of the questions that were in the chat that came in, and they were answered for sake of time. They were answered in writing. And so there was a question about biopsy. Potentially, is it true that biopsy can sometimes end up spreading cancer cells to other parts of the body? And if you want to summarize really briefly, Dr.
Yeah. So that is highly unlikely. But for the biopsies I described, and from the vast majority of biopsies, if not all, the mechanism is you put the needle right next to the tumor, and then through that needle, you put another smaller needle just into the tumor, and then you remove it inside the bigger needle so nothing can spill anywhere else. This has been the standard practice for years and has shown not to cause local recurrences. So I think that hopefully this will reassure people. But alternatively, let's say you have a nodule, you don't have to have a biopsy. Just follow it for a little bit, and if it grows just have it taken out. That if you're so concerned about the needle. But I think that what was described is a common concern by people who, and that's why I explain how it's done to reassure everybody.
And then just to kind of circle back a bit, why you mentioned, Erica, that radon is in the home or in the schools and things. Where is that exposure coming from? You know, like we have lead and paint and things of that nature. It's like, what is the source of the radon?
It is a completely natural gas that occurs in the earth. And so as you dig down to build a home or build a foundation, the radon can be released. Some areas of the country are more prone to higher levels of radon. My parents live in Iowa, and Iowa is notorious for having high levels of radon. And indeed, once I started working at the Lung Association, they got tested right away and had their home mitigated because it was higher than it should have been. So I think that, but radon can appear anywhere, and so it's very important that buildings are tested.
And so I know we're coming to the close. And so before we wrap up, I want one last question for you guys. We often have patients and healthcare providers that log in, as well as researchers, policy professionals that tune into webinars and public forums like this. What is one takeaway that each of you would recommend to viewers, either in one of those categories or broadly, to help them support or convince them to support research in preventive care for lung cancer in women? And so we can start with Dr. Bueno, and then we'll end with you, Erica.
Well, I think that supporting research, tell your congressman to make sure that they get the NIH the budget it needs to select the best projects and fund them, because every year someone is threatening the budget and then someone wants to cut the budget.
I would say in terms of advocacy, it's definitely supporting and articulating support for NIH, but also for CDC. The single best kind of cancer that you can that's out there is the one you never get, right? And CDC does so much work at the community level across the board for tobacco, but for a whole host of other things to work to increase prevention as well as early detection for lung cancer and other cancers, and not having even to go through a cancer diagnosis is very important. And certainly we want to prevent as much as we can. And so investing across the board in all of this is so important, as well as NIH for early detections and treatments for lung cancer. But I would just say that in general, it's a knowledge that no one deserves lung cancer. And that with lung cancer, with so many new treatments for people who are diagnosed at stage 4, that people can live with lung cancer and live a very full life for a whole number of years. We have an incredible patient advocate in Florida. She was diagnosed with stage 4 over 11 years ago, and has been she's participated in clinical trials and has been on immunotherapies that have led to a very good life for her and for her family. And so there is hope for people with lung cancer, and the more we can raise our voices about prevention and early detection, the better off we all are.
Thank you very much. You guys have been an amazing panel. Thank you so much for your time and your insight. And I'd also like to thank Roche for their support of this public forum and SWHR's Value of Diagnostics Within Women's Health series. We thank everyone in the audience for joining SWHR during this series, highlighting various areas in women's health that benefit from innovations in screening and diagnostics. We also invite you to visit our website, www.swhr.org, to watch the recordings from the entire series of public forums. You can also connect with us on social media to register for future events, download women's health resources like our fact sheet on lung cancer in women, and sign up for our newsletter. We will be sending out an email with a recording of today's webinar to all registrants, as well as post a recording on the events webpage for future viewing. And you'll be able to also see have access to those slides there. So please be on the lookout for that, and feel free to share widely with others as we continue this conversation of hashtag SWHR Talks Diagnostics and hashtag SWHR Talks Cancer. Thank you for joining us.